We always try to take into account the individual patient sitting in front of us, and I made a few comments previously about that. So depending on the comorbidities a patient may have, their functional status, the extent of the disease, et cetera, those things are all distilled into making a decision about what's best for the patient. So yes, we do take into account the individual expected side effects of a therapy, and we try to consider whether that patient can tolerate those things. And as I mentioned with the obvious example, if somebody has underlying interstitial lung disease, do you want to give them trastuzumab deruxtecan? Maybe not, or do so with a great deal of caution. Again, if somebody has GI symptoms, maybe an antibody-drug conjugate that has GI side effects may not be your optimal choice. So again, these are things that we think about when we make decisions about a patient. And of course, that goes into the calculation about what is best for that patient. Well, the only way a patient is going to gain the benefits from a therapy is if they stay on it. So rather than torture them and have them come off, we'd rather make dose adjustments. We've learned in patients that get, as an example, CDK4/6 inhibitors, that if you modify the dose in order to mitigate some of the side effects, we see that the efficacy is the same and the patients tolerate it better. It's no different when we're thinking about HER2-directed therapy or any other kind of therapy. We want to still keep the treatment dosing within a range where we expect efficacy, but I would have no hesitation on decreasing the dose in order to make a potentially effective therapy continue on so that the patient can tolerate it. Because again, as has been a point made by many people speaking at this meeting today, in metastatic disease, it's a long journey. You want to keep patients going, but at the same time, you want to make sure that you don't diminish their quality of life by the therapy you're giving them. The disease is already impacting on them. So, we want to make sure that the therapy is as tolerable as possible. Well, I chair the NCCN committee, so I hope I abide by them. But that said, we try to make the guidelines so that they are evidence-based, and they're a framework. There are exceptions to any guideline, whether it's ASCO, NCCN, ESMO, whatever, St. Gallen. There are going to be exceptions, but usually when you're thinking about guidelines, it's not necessarily in the context of a cookbook, but rather trying to make decisions based on the level of evidence that supports putting them in the guidelines. So, we try to make guidelines so they capture the vast majority of patients in a particular clinical situation, but there may be individual patients where you deviate, and that's not wrong.